This elderly lady attended reporting unilateral right-sided tinnitus. So tinnitus is any sound that originates within the ear or the head that's not due to an external stimulus. In addition, she has long-standing right-sided hearing loss. She's previously seen several audiologists over the years who have recommended hearing aids. Her son visited me a couple of weeks ago to have wax removed, and after that appointment her son felt it would be beneficial to also book her mum in for what he believed was initially just a hearing consultation. Previously you would have seen images of both the patient's left ear and the right ear, so this is the patient's right ear. When I first examined the ear, you can see there is some keratin there, but it looked quite innocuous. It's quite often you get patients with dead skin keratin coating the eardrum, but it doesn't really affect them in any way. But with this particular client, I actually performed a procedure called tympanometry after examining her ears. And tympanometry is a pressure test, and it evaluates the mobility of your eardrum and the three tiny bones attached, the ossicles. It also assesses the function of the eustachian tube. So in essence, the tympanometry assesses the middle ear function, but it can also advise us as to whether the eardrum itself is mobile or it's stiff for whatever reason. In this case, the tympanometry results for her right ear showed that the eardrum wasn't vibrating very negligibly anyway, whereas her left was. When you visualize the ear at the beginning on the eardrum, it looked like a little bubble there. So at first I suspected possible middle ear effusion, so the patient had some fluid behind the eardrum, but when I really examined closely, I realised that there wasn't any effusion, any fluid behind the eardrum causing that bulge. It was just this really crinkled and crusty layer of hard dead skin keratin, and I began to wonder whether this was the cause of her symptoms. As I said earlier, when you first examined that ear, it did look quite innocuous. You would just think, okay, a bit of keratin on the eardrum, it's not going to cause that much of an issue. It will naturally shed and migrate. This patient reported her tinnitus and hearing loss in the right ear to be for about 20 years. You can see the skin is very, very embedded, very tough, very difficult to peel. We also had to be extra cautious because when we do peel keratin, or even if we remove wax off the ear canal wall, we can elicit the gag reflex, so the patient can cough. And during these COVID times, although the patient's all wearing face masks, we really want to avoid that if possible. So I did ask the patient to advise me prior to her feeling that she may want to cough, so we can stop immediately, and she's really good. Initially I went to try and peel the keratin off the eardrum directly, but it just wasn't budging. So what I did then, I removed the keratin further away from the eardrum off the canal wall and peeling it all the way towards the eardrum. Sometimes when you do that, if you start peeling it from laterally, so from the ear canal entrance, and you peel towards the eardrum, it can then help separate the dead keratin off the eardrum. And that's what we're trying here, but I've peeled the skin off the canal wall, but there is some more later in the video that you will see. We will be doing some more later from the external auditory meatus, the ear canal wall, but it's just not coming off the eardrum still. I used some forceps, just teared it into little pieces. And this is quite often you'll read comments, well, why didn't you use forceps? It's a classic example there. Forceps sometimes just basically slices and cuts dead keratin in pieces. It doesn't really help you to peel it, and suction is often the best. Initially I was using a fine end gouge. A fine end gouge is less suction power, but it's an extension to the Zollner suction probe with a narrower tip. It's more precise. It's meant for finesse procedures when we're close to the eardrum, because if it does come in contact with the ear canal or eardrum, it's less likely to cause trauma. It's also less noisy. But that fine end just really wasn't cutting the mustard. It wasn't powerful enough. So I've had no choice here but to resort to a standard Zollner suction probe. And because the diameter of the standard ulnar suction probe is almost double that of the fine end, and we're working directly on the eardrum, we just have to be so careful that we don't cause any injury or trauma. The patient, though, I must admit, was fantastic. She was really, really still. She actually felt as though she was enjoying the procedure from time to time, but she did also feel when I was tugging away from the eardrum that there was some plastic. She felt it. She could best describe this dead keratin as a sheet of plastic, and she can feel it. So again, I did peel some off the attic of the eardrum. I've just gone back in with the fine end again just to see if I can get a bit deeper and literally onto the eardrum itself, which would be very hard to do with a standard ulnar suction probe. But again, I'm just peeling away then. It's very stubborn, it's probably the most impacted and thickened layer of keratin I've ever had to remove. And again, you can see there, we're just peeling it off the anterior medial canal wall. Where I've just peeled that, you can see there's a bit of blistering occurring on the canal wall, and that can happen if you've got some dry skin on your finger and you peel it, you can quite easily cause a blister. Just gone back in with the forceps again just to see if I can peel away this off the tympanic membrane, the eardrum, but as you saw, it just shredded it. At this stage, I've instilled some sodium bicarbonate earwax drops, and you can see the middle of the eardrum there, that kind of bubble appearance, and one can be forgiven almost, an audiologist, if they've examined that, to assume that it's effusion, so middle ear fluid causing that bulge, but in this case it wasn't. That was the dead keratin. There was a crinkle in the dead keratin at that region, giving that appearance. Sodium bicarbonate earwax drops tends to work really well with dead skin, more so than olive oil drops, but it didn't really do much, if I'm honest. And I'm just really pulling away there in the anterior recess, and you can see it's just starting to peel away in the anterior recess, more towards the attic, but it is so stubborn. It was a bit nerve-wracking as well because the patient's son was over my shoulder watching, and he was gasping quite a lot because he couldn't believe how close we were to the eardrum and how stubborn that keratin was. I don't particularly mind if patients watch me. I've done the procedure enough now. I'm quite confident, so it didn't really cause me much of a distraction. And again, just going back in with a fine end, just really trying to peel this off the roof of the canal wall and off the attic of the eardrum. But as I'm peeling there's a lot of resistance, and I was explaining to the patient and her son, I compared the procedure to trying to delicately remove some stuck sellotape off some paper that's really been dry. It's been stuck for a while, and without tearing that paper. And I was comparing the eardrum to be the same thickness as a sheet of paper, and this keratin to be the sellotape, and we're having to peel off this keratin off the eardrum without perforating the eardrum, to be quite frank. So it is a very delicate procedure. It's not something you can just go in there and vacuum and yank out. Patient is awake, no general anaesthesia, no local anaesthesia. I have seen some procedures, I think in the Far East, where they remove keratin off the eardrum using ear hooks, but you can be quite rest assured that the patient either has local anaesthetic or general anaesthetic. I would assume it was more general GA rather than LA used in those procedures, but we don't do that here. Try and do everything, the patient completely awake, and sometimes it can take longer, but again, I'd rather be cautious and precise, taking longer than getting impatient and doing something silly where I can cause permanent trauma to this lady's eardrum. Another sheet of dead keratin there. Again, just going to go back in. I think this is the fine end gauze, because I'm just trying to get really deep into the anterior recess, and I wouldn't really be able to do that with the standard ulnar suction probe. The side of the suction probe will make contact with the bony part of the ear canal. So if you've been watching my videos, you would know that the anatomy of the ear canal is that the outer third is made up of cartilage, and it's got some fatty tissue. and that creates a buffer effect. If you make contact with the cartilage portion of the ear canal, it doesn't really cause any pain to the patient. If you imagine, if you just wriggle around in the outer part of your ear, it's not painful at all, but the inner 2/3 of the ear canal, it's actually a very thin layer of skin coating bone, and that bone is very sensitive. If you make contact with that bone, the patient can really be in excruciating pain, make sudden movements, and we can cause more good than we are trying to hear, sorry, more harm than we are good. And so just using the standards on the suction probe, and I've gone to the outer third here on the cartilage portion, starting to peel that. When I was on the cartilage portion, I was able to kind of make contact with that cartilage, but as I peeled away towards the eardrum, I was just being careful not to make contact with the bony part. And again, I was just hoping that if I start peeling laterally medially towards the eardrum, that this will loosen that keratin off the eardrum. But you'll see a bit later on that you can see some more keratin there. I did kind of peel all that off, but it didn't really help me remove this keratin off the tympanic membrane. You can just see how much I'm tugging there. It's so tough, such a thick layer of keratin stuck, embedded. There's no real other instrument I could have used here. I used the forceps, and I showed you earlier, it was just tearing pieces. And I'm really just tugging this from the right to the left, trying to release it from the anterior recess. And then in a moment, I think I was going inferiorly into the inferior recess. There was a lot of keratin there as well. Just trying to lift that up. I think in a moment, well, a bit further on, I'll be using some more drops in the procedure. Later I use some olive oil drops. I use sodium bicarb, which works generally really well with dead keratin, but it didn't really assist me in this particular patient, so I thought I'd try some olive oil drops instead. And what's amazing about endoscopic earwax removal, so we use an endoscope. It's the iClearscope, which is a device that myself and my colleagues at Clearwax developed. An endoscope provides such a fantastic view of the whole eardrum. There is some other magnification devices such as loupes, which generally don't provide this level of magnification when you're looking at the eardrum. In fact, some loupes, you just can't see this far down the ear. You could also use an operating ENT microscope, what they use for ear surgery. And yeah, an ENT microscope, the magnification is fantastic. The limitation of a microscope, however, is that you get a very narrowed view. You won't see the whole ear canal or the eardrum. You will probably see a quarter of what I'm seeing at the moment. And in these kind of cases, being able to visualize the perimeter of the ear canal really does help, because I know where the skin is attached. There's no guesswork. I'm not having to move the patient around to get differing views as I'm trying to peel this skin. So this is the real benefit of an endoscope. Not only can I get a fantastic view of the eardrum, but I can also see the whole image in one go. So I know how to manipulate and work this keratin off. Just in the last clip there, you would begin to see that this keratin was beginning to kind of detach itself from the eardrum. And I think the patient felt also some movement of the eardrum, and that's why in a moment I decided to put some olive oil drops, just to see if this olive oil can get in behind the keratin, kind of in between the keratin and the eardrum, provide some lubrication to help release it without the patient also feeling the eardrum tugging at the same time. My hand was a bit tired by this stage, and some of you viewing this might think, oh, this is really boring, what's he doing? He's just messing around in there. This is the reality of clinical ear care. I can guarantee you a lot of patients, even on myself, when I first began this procedure, I was a bit nervous, because whenever you go this close to the eardrum, you do get a bit nervous, a bit anxious. You don't want to cause the patient any injury. And this keratin has been in there for many years. This patient has, as I said, seen many specialists previously and never had this keratin removed, she reports. And what's fantastic, at the beginning I mentioned she had long-standing hearing loss in the right ear and unilateral tinnitus. She immediately felt such a relief from her hearing loss as I removed the keratin. As it removed, she found a significant improvement in her hearing in this ear. The tinnitus was still present, but it was less noticeable, which is fantastic anyway. And we're hoping that as the ear settles, that tinnitus can become less and less noticeable. I have provided her with some realistic expectations. When you've had tinnitus for 20 odd years, even if this was the cause, it's been there for so long, and there's no guarantee that that tinnitus will just by itself alleviate and be resolved just by removing this keratin. But we are now hoping over the next few days, weeks, that although her tinnitus has already subsided, whilst giving realistic expectations, I am hoping that it will become even less noticeable to her. And again, I've just used some olive oil drops there just to see if this olive oil could get in behind the keratin in between the eardrum. It was a good time applying it now because I was able to detach some of this keratin. You can just see in the right hand side there's a bit of an opening there where the oil hopefully would have got through the keratin and in behind the keratin where it's embedded on the eardrum. Again, just using the Zollner suction probe, it's really tugging at this, and it is patience is a virtue with these procedures. You just have to tugging away. You can't overexert yourself this close to the eardrum because, as I said, one false move, you could quite easily perforate that eardrum. And again, we have to bear in mind the patient is awake. We have to do things gently because if that patient makes a sudden movement, it can again cause me to perforate her eardrum. We do have a brace that we can accommodate for sudden head movements, but when we're this close to the eardrum, you do have to hope that my reaction time is very quick if the patient does suddenly move. So again, just peeling some of this, and at this stage I'm just peeling backwards, I believe. This keratin that's coating the canal wall, I'm just getting it medially and coming outwards. I think I will be doing that anyway. Let's see. There we are. So I'm just peeling back here. Whilst I was in there removing the keratin, I thought, well, this has become loose. Let's see if I can remove this. And again, I just have to be a bit careful now. I'm near the canal entrance. When I say careful here, this is where you can elicit the gag reflex. So although I can make some contact and the patient's not going to feel that it's uncomfortable, when you do make contact, which I wasn't closer to the eardrum, to the canal wall, you can elicit the gag reflex. There's a nerve called the Arnold's nerve at the base of the ear canal, and you can quite easily stimulate that. And I just don't want the patient coughing at this time due to COVID-19. Again, I've loosened that big sheet of keratin off the base of the ear canal, and again, it's just loosened some of it off the inferior quadrant of the tympanic membrane, so the lower portion. I think I'm going to use some forceps again just to get rid of this tail of dead keratin. There we are, but unfortunately it just the forceps wasn't helping me to peel it off the eardrum. Back in with the suction probe, and I think we're coming to the latter stages of the procedure now. So ideally, at the beginning, you saw us peeling off the keratin from the entrance of the ear canal towards the eardrum, hoping it would help me release the keratin off the eardrum, but actually it didn't. In this case, I did it the opposite way. I kind of detached the keratin medially, so close to the eardrum, and just came back and peeled it away from the canal wall. Did so, removing that keratin off the ear canal did in no way assist me in this final bit of removing it from the eardrum. And here's where finally I was able to you can start to see that keratin really loosening now. It's become really mobile. Just going back in with the I think at this stage I was using the fine end again because I loosened a lot of that keratin, and you can see now how I'm just working this. I'm just really tugging left to right, and it does look like a plastic, and it did feel like a plastic. It was really hard and crinkly and coarse and rough. And we're nearly there now, so you can just see it's still attached to the posterior canal wall there, where I'm stretching it off, coming forwards. And there we have it. And you can see how glossy this skin is, so it's really, it's almost like glass actually when you look through it. It's really translucent. There's the eardrum. There's a few blistering there. Naturally, you're going to get blistering in this type of procedure when we're peeling really thick keratin. So there's 3 red marks. They will settle down. This is I've taken an image using another video otoscope, an otocam, so you can get more of a kind of a distinct view. There's the dead skin and in a minute you're going to see an enlarged image of the skin that was directly over the eardrum. I repeated tympanometry, the pressure test, and the patient's right eardrum was fully mobile after the procedure. She was really pleased that she came to see me. She was over the moon, not only because I managed to remove that dead skin, I was able to help her. Her tinnitus had improved significantly and her hearing had also significantly improved. Hope you enjoyed that video, guys. I hope you're all keeping well and safe, enjoying your